Good afternoon, everyone. I'm honored to be asked to present this content today, and given my work at the Institute, the Hartford Institute for Geriatric Nursing, I'm really excited to be a speaker for the webinar series in collaboration with the National Gerontological Nursing Association. Before I begin, I wish to advise you that I have no actual conflicts, actual or potential conflict of interest in relation to this presentation. Our objectives for today include identifying ethical and legal issues in geriatric medicine, and an emphasis will be placed on dementia, particularly Alzheimer's disease, to discuss the role of the nurse in addressing challenges and employing best practices, to provide dialogue and guidance on daily practice issues in the care of older adults, and to identify policy opportunities to move an advanced care agenda forward. So as we begin to think about ethical and legal issues in the news, one of the things that's really important is that daily in the print and sound media there are ethical and legal questions being discussed. Oftentimes these questions concern the care of older adults. Our patients and families, as they approach a myriad of health-related issues as they advance in age, come to us with expectations that are formulated from the media. But I think at the end of the day, one of the ethical concerns that providers, nurses in particular, as well as families address, and they experience a great deal of moral distress related. It's relating the issues of feeding dementia patients and the absence of feeding. The notion about hand feeding or tube feeding, what are the benefits and burdens of each. The American Geriatric Society has actually written about this and have really talked about comfort feeding and the terms that we use to describe this feeding, and that the idea that if we don't have a medical order that says no artificial, if we do have a medical order that says no artificial hydration and nutrition, how does that resonate in a way that makes families as well as providers uncomfortable? But as we think about how we refer to this and we think about comfort feeding, there is support that that may be a term that's more appropriate. So I hope that in those few slides you've begun to see some of the headlines that that we've seen in recent time that our patients and families, or certainly our families, are reading, and they come to us with those headlines and with that knowledge that's articulated by sometimes a medical provider or certainly a journalist that really begs to question about our own ethical and professional responsibility to be informed and learned about these various questions. As we think about ethical and legal issues in geriatric medicine, do know that over the last 15 or 20 years, there's been an increased amount of literature, both in bioethics as well as in geriatrics, related to geriatric medicine. So as we think about the ethical issues that arise in geriatric medicine, certainly they are similar to those that arise in the care of younger patients, but certainly dilemmas concerning decisions about care at the end of life are particularly relevant for geriatrics patients. Choices about life-sustaining therapy when critical illness occurs really brings this to the forefront. So certainly you can recognize the names here, Dr. Christine Castle as well as Marshall Kapp, and others have really written in the area over the last number of years. And so currently, decades later, we've got a growing body of literature. And certainly our colleagues at the Institute have informed that literature as well. So when you think about the prevalence of dementia and Alzheimer's disease, I want us to take a quick look at this video and let it sort of give us some of the demographics, if you will, about the disease. So when you think about the prevalence of the disease and the burden of the disease, I think that particular clip really resonates in a way of really underscoring that, in fact, this is an epidemic. The sixth leading cause of death, greater than 5 million Americans live with it. Every 67 seconds, someone in the U.S. develops the disease. 1 in 3 seniors die with the disease. And I think the other important piece for me in seeing this fact is the burden of the disease on women, that women are primarily caregivers, and yet women also present 2/3 greater with the disease. So when you begin to think about characteristics of advanced dementia and related ethical questions, Marshall Kapp again earlier has written and provides us with this framework that the characteristics certainly include an inability to care for self and live alone, the inability to make medical decisions, the incapacity is present but not always permanent, capacity, certainly a major concern in this area, may be transitory and may vary based on the time of day, the surrounding and location and the environment that the individual rests, medications, support, or aggravating circumstances and systems, and the effects of temporary and treatable illnesses all impact and really present as characteristics of advanced dementia. But as we think about these questions and know that each stage raises ethical concerns, one of the things that I think it's important for us to remember is that we're really talking about the individual, the person, and not the disease. One family care giver made the following statements. Daddy was the rock, the average storyteller, and the keeper of the family flame. He was once so very strong, courageous, a deep-sea fisherman, a huntsman, a family man, so full of love and life. And at the dawn of age 85, Daddy slowed slipped away into a fog of Alzheimer's disease. Now, she says, all of Daddy's stories are written upon his face. And I think her expressions reminds us that we're really talking about the individual, the person, and not the disease as we think about some of the ethical and professional considerations while caring for older adults. So as you think about what are some of the questions affecting the healthcare team, and certainly these questions are germane to nursing as well, is we ask questions such as, who makes the healthcare decisions when the patient cannot make decisions him or herself? What happens when family members, caregivers, and members of the healthcare team disagree with each other, the patient's previously stated wishes, and or the plan of care? And then what do you do when members of the healthcare team have conflicting ethical values or are governed by other practice guidelines? And how do we maintain autonomy for the patient as we work in teams and groups, and each of us are committed to wanting to do good and not to cause harm to our patient and family? And so there are 4 ethical principles that are largely at play that will help us answer these questions. And certainly Beauchamp and Childress has written extensively on these principles. And so we're looking at the principles of autonomy, beneficence, non-maleficence, and justice. So let's quickly look at these in turn. So as we think about autonomy, we certainly know this is to be an American value. We espouse great respect for individual rights and equate freedom with autonomy. And our laws also support autonomy and upholds the rights of individuals to make healthcare decisions or to make decisions about their own healthcare. And so as we think about respect for autonomy, it requires that patients be told the truth about their condition and to be informed about the risk and benefits of the proposed treatment. And under the law, patients are permitted to refuse treatment even if the best and most reliable information indicates that the treatment would be beneficial. And sometimes this is one of the hardest aspects of our care, is to really respect the patient's choices or family choices, even when we try to present evidence to the contrary, and our experiences also suggest to the contrary. And so these kinds of situations really sets the stage for ethical dilemmas. When we think about beneficence, on the other hand, it's certainly our ability or the willingness to do good, the act of being kind, the act of really doing what's in the best interest of the patient. And really these actions that we engage as healthcare providers are really designed to help bring about this good, this positive good. And it certainly, beneficence also raises the question about, you know, subjectivity and objectivity in terms of what is good. You know, what are the determinations to benefit versus, or benefits versus harm. When you think about non-maleficence, we say that this is the meaning to do no harm. These actions that are taken by healthcare professionals all the time, you know, we really want to engage in care that doesn't cause harm, and of course we want to avoid the negative, the consequences of harm. And so one of the areas, particularly those who are caring for older adults and certainly those with advanced dementia, includes the right of the individual to choose to die with dignity. And certainly that's really undergirded in the principle of autonomy, but it's difficult sometimes for healthcare professionals to accept death when there still may be some viable options. And so in that case, the principle of non-maleficence would conflict with the principle of autonomy, and that really gives rise to some ethical tensions. And so lastly, as we think about the principle of justice, we think of justice really being grounded in equity and fairness, but it's important for us when we think about older adults to think about distributive justice as compared to comparative justice. Distributive justice really addresses the degree to which healthcare services are distributed. Are we distributing them equitably and fairly? As compared to comparative justice, we're really looking at whether health care is delivered at the individual level. And in a society where we're grappling with equal access to health care, certainly there's evidence that there isn't equal access to health care, and the Affordable Care Act is one policy effort that's promulgated to address that concern. But comparative justice really requires us to look at health care and how it's delivered at the individual level. So professional-patient relationships are grounded in principles of veracity, privacy, confidentiality, and fidelity. We know that ethical dilemmas occur, as I said earlier, when we must choose between two or more equally unfavorable alternatives, or we have a problem that's seemingly incapable of a satisfactory solution. And laws, on the other hand, are rules that are prescriptive, and they're really there to prescribe as the governmental authority that has legal and binding force. So as you can see here, when we think about ethical dilemmas that are grounded in conflicts of ethical principles on the one hand, and on the other hand, when we think that there are laws or rules that are prescriptive, that are really enforced through a governmental authority that has a legal and binding force for enforcement. So ethical challenges in geriatric medicine that really gives rise to some legal consequences, and that we'll look a little at in the case study in the upcoming slides. We really think about issues related to consent and mental capacity. We think of issues related to advanced directives, whether we're looking at durable powers of attorney for health care or the living will. And certainly in many states, although these are not per se advanced directives, we're learning more about the MOLST in Maryland. We have the medical orders for life-sustaining treatment. Others have the PULSE and other versions of that. The do not resuscitate order, we see that as a type of a directive, although not a formal, when we think about the durable power of attorney for health care and the living will being the formal documents. But a third issue that is certainly an ethical challenge for those in geriatric medicine includes notions of withholding or withdrawing prolonging or life-sustaining medical treatment. And so autonomy versus beneficence. Again, the overarching ethical principles for consent and mental capacity are grounded in these two principles. Autonomy being the ethical value, if you will, and informed consent giving rise to the elements, the law that's required when we're grappling with whether the individual has the capacity to participate in the consent process. And so when you think about the elements of informed consent, we see that the individual must have the capacity or the ability to make the decision. The medical provider must disclose information on the treatment, the tests, the procedure in question, including the expected benefits and risk, as well as the likelihood or the probability that the benefits and risks will occur. Information must be communicated in a way that they can comprehend and that it is relevant, and that the individual must be able to voluntarily grant consent, and that they're not being coerced or they're under a situation of duress to consent to the proposed treatment or therapy. When we think about dementia and autonomy and decision-making, it's important to revisit that, as Marshall Kapp reminds us, that dementia results in the progressive loss of capacities. The progressive loss of these capacities, which is the foundation for autonomy and informed consent. And that ethical principles such as beneficence and non-maleficence outweigh the ethical principle of autonomy over time. And that's important, that we think about over time as the symptoms present itself, and as we move forward with managing those, we really start to see that how principles of beneficence and non-maleficence really start to trump principles of autonomy. So when we think about the legal landscape, the legal principle of parens patriae, the Latin term for sort of the state being the protector, if you will, and that the state wants to protect those who are not able to protect themselves, and the legal system has many mechanisms in place for really carrying out that mandate. So whether it's the determination of incompetence, and again, we're all presumed to be competent until proven otherwise, and the development of advanced care planning, and particularly around durable powers of attorney for health care, or the completion of living wills that gives rise to this movement about advanced care planning, are all available there to really recognize that beneficence and non-maleficence does outweigh over time. And so as we look at autonomy versus non-maleficence, it's important to think again that competency is a legal determination and is not the same as decisional capacity. When we think about decisional capacity, we really think about functional capabilities, our functional abilities, that the person may not be legally competent to make decisions, but may have transitory capacity. So it's important when we think about the MMSE or the Folsteins and some of these other measures that we really think about that the person who may not be legally competent may still have some functional capabilities. That families and professionals may erroneously assume that patients with dementia have no capacity to make decisions. And then lastly, that there's this constant tension that Woods and colleagues addresses that happens between not causing distress for persons and giving persons as much control as possible. So there's that tension of trying to balance that, yes, we want to respect the individual's autonomy, but we really don't want to cause stress or distress, and that would then give rise to the principle of non-maleficence. So again, we talk about the person and not the disease, and I want to introduce you to Mr. Hunt, Mr. John Hunt. It's a quick video here that I'm going to try to pop up in the meanwhile?
Well, I always thought my father was the most handsomest man in the whole world. As a little girl, I would stand on top of the commode while he shaved and combed his hair. He was always a very, very loving father and very giving. My father was an avid gardener, and he would sneak down and put Miracle Grow on the plants at night. He just wasn't himself. It hurt to see my strong, courageous father be so fragile. So I would be strong, but in the evenings I would cry. Father and mother retired and moved to another state, and she had me to come home. And I bathed my father and shaved my father, dressed him, and feed him because it was just too difficult for her. On the medication, I was able to sleep during the day and certainly get through a night. So it was a godsend. I only have to give them one call a day as opposed to 3 calls a day, and not so much holding both of my parents' hands.
Sorry about that. And so that was a family caregiver really speaking to the impact of the disease as she talked about her father and what the disease looks like. So who is Mr. Hunt? Mr. Hunt is an 85-year-old man with end-stage dementia living in a Veterans Administration hospital. It's a 29-bed unit that is a designated Alzheimer's unit. He's been married for 55 years and he has 9 children. His wife and 2 children disagree with the proposed treatment that the providers are recommending. The wife wanted treatment to save his life, as she repeatedly stated, and that treatment also includes antibiotics and later insertion of a tube feeding, of a feeding tube. While 2 of the children did not want treatment and disagreed with the physician's recommendation to not treat, and they felt that the father wishes should be honored and that he should be allowed to let him go. So what should the interdisciplinary team do, given that you've got these 2 perspectives? The wife asking to do everything, save him, and 2 of the 9 siblings saying, let him go. Well, as we think about withholding tube feeding in patients with advanced dementia, these questions are certainly for those on the front line or every part, or very much a part of your day-to-day practice. And as you think about issues to consider, whether they're the benefits and burdens of artificial nutrition and hydration, the legal and moral aspects of tube feeding, withholding and withdrawing life-sustaining treatment, as well as the general notion about tube feedings with patients, in patients with advanced dementia. This summer, we really were fortunate to have further guidance by the American Geriatric Society and their position statement on feeding tubes in advanced dementia. I think this was in June of this year. This particular statement was published, and I think that this statement really resonates in a way, and it's quite helpful for us as we think about Mr. Hunt and his family. So the recommendations are, generally speaking, that when eating difficulties arise, feeding tubes are not recommended for older adults with advanced dementia. That careful hand feeding should be offered because hand feeding has been shown, there is evidence that it is as good as tube feeding for the outcomes of death, aspiration, pneumonia, functional status, and comfort. So again, that hand feeding should be offered because hand feeding has been shown to be as good as tube feeding for the outcomes of death, aspiration, pneumonia, functional status, and comfort. And that efforts to enhance oral feedings by altering the environment and creating this patient-centered approach is helpful, that it is the responsibility of all members of the healthcare team caring for residents in long-term care settings to understand any previously stated wishes of the individual, and that institutions also have a responsibility. And so let's look at each of these in turn. So here up on the screen, I have the very first recommendation, and that is, as expressed, that feeding tubes are not recommended for older adults with advanced dementia, that careful hand feeding should be offered for persons with advanced dementia, that hand feeding is at least as good as tube feeding for the outcomes, that tube feeding is associated with greater with agitation, greater use of physical and chemical restraints, greater healthcare use due to tube-related complications, and development of new ulcers. And so that's important in terms of their first position. The second recommendation is that efforts to enhance oral feedings by altering the environment and creating individual-centered approaches to feeding should be part of the usual care for older adults with advanced dementia. And that tube feeding is a medical therapy that an individual surrogate decision maker, Mrs. Hunt, can decline or accept in accordance with the advanced directives as previously stated, or what is thought the individual would want. And that's where some of the tension came in among the family, is that there was a disagreement about what they thought the individual would want. Two of the siblings thought that the father would ask to let him go, and while the spouse and other siblings thought that further treatment would be indicated. The fourth provision is that it is the responsibility of all members of the healthcare team caring for residents in a long-term care setting to understand any previously expressed wishes of the individual regarding tube feeding and to incorporate those wishes into the care plan. In this situation, there was no express preferences about tube feeding, and so the family didn't have per se guidance about tube feeding from their loved one. Institutions such as hospitals and nursing homes and other care settings should promote choice, endorse shared and informed decision making, and honor individual preferences regarding tube feedings. And they should not impose obligations or exert pressure on individuals or providers to institute tube feeding. And so, again, two of the siblings were arguing that they felt pressured to go along that way when they felt, in their good faith belief, that the father preferences were otherwise. So this situation really gives rise to a myriad of concerns related to family as caregivers. Family makes decisions as cognitive impairment increases and the decisions encroach on autonomy. And cultural and religious influences also has a major impact as the disease progresses. Deeply held religious beliefs and cultural attitudes about caring for older adults are really a part of the tension and the dilemmas that families address when they speak to about being family caregivers. So when we think about family as caregivers, how should health professionals view the interests and outcomes and concerns of patients' family members who bear the burden of care? What are the obligations for caregiving that come with being a family member? And are there limits to these obligations? And is it ever acceptable to say, I can't do this, or I don't want to do this any longer? And so when families are grappling with caregiving and how we as a society and certainly as healthcare team really want to include the family in decision making and the family care, a movement is afoot that's spearheaded by the AARP that's really moving forward with this CARE Act. And this CARE Act is largely born out of the notion that we are expecting families to do so much more, and they're not prepared. And so there are 3 states, or at least Hawaii, Illinois, and I believe New Jersey's State Hospital Association had opposed it, but I think they were among the states that were looking at this particular legislation that has already been signed into law in Oklahoma. It's called the CARE Act, the CARE Act. And the CARE Act has 3 important features that's important for our families who are now care providers. The first is that the name of the family caregiver is recorded when a loved one is admitted to a hospital or a rehab center, so there's an opportunity to know who that person is and to work with that person. The family caregiver is notified if the loved one is to be discharged to another facility or back home, and that the hospital or the rehab center must provide an explanation and live instructions of the medical tasks that they are going to be responsible for and to provide at home. And this particular legislation, again, is really being instituted and developed by AARP, but it's certainly some adversaries to this law is saying that we already do this, there isn't a need for this, but certainly there are many more who say that too many families are receiving their patients back at home and they're ill-equipped to really be able to provide the care that's needed. So this is an important policy issue that I encourage us to watch. When we think about caring for the Alzheimer's caregivers, Judith London, Dr. London, has this book, Support for Alzheimer's and Dementia Caregivers, and she refers to them as unsung heroes. And I do believe that, in fact, they are very much our unsung heroes. In wrapping up, when we think about the context of end-of-life care in our country, I would be remiss in not mentioning that in September, the Institutes of Medicine, which had a 21-member nonpartisan committee, really produced a 500-page report that looked again how we are dying in America. And the panel really urges for a major overhauling in healthcare as we look at care at the end of life. So I encourage you to go on their website, the Institutes of Medicine's website, and look for this report entitled Dying in America. What's important about this report, there is provisions and sections that really address care of older adults and those with late-stage dementia. And they cite the work of Unroe and Meyer in looking at the burdensome transitions in the interventions that cause discomfort and produce little gain among our patients and families. And I have here in red that although we understand the characteristics that present with individuals that are at the late stage of dementia, a minority of the Medicare descendants that they looked at with dementia are referred to hospice before death, and repeated burdensome transitions between hospitals and nursing homes, as well as feeding tube placements, currently occur. And again, each of these really give rise to some of the ethical tensions that we see at the end of life and in caring for our patients and families. The report goes on to look at domains of clinical competence in end-of-life care, and I encourage you to look at that provision. And I want to leave you with the idea that ethics committees are available. Certainly if you find yourself in an acute care setting, for those who are in long-term care settings and more ambulatory care settings, assisted living, we may not see them as much. But I want us to be reminded that ethics committees are a wonderful resource to us to help us when we think about decision-making and resolution of ethical dilemmas. That they can certainly help us as we think about reasoned analysis and clinical judgment. They're there for consultation, and certainly they have members who, individuals who are there from the risk management and who are lawyers, attorneys, that can help us with the resolution of the question. There are changes that's going on in JACO that it's important for us to keep in mind. And one of the areas was new certification standards this past July as it related to the nursing care centers. So I thank you for your time and your attention, and we've just got just about 10 minutes remaining that I can take a couple questions from the participants.